Most definitely time for Ultimate Health on Joy 99.7 FM. With me in the seat, you know it's complete. My name is Nortey by nature. The program is Ultimate Health on Joy 99.7 FM.
Joy 99.7 FM.
I feel to my brothers and sisters in Gamashi, right? Myself in some hectic traffic. They're still doing the do. As usual, I'll start with my praise. Couldn't get a song called Coco, yeah? But I'll take Coco from EL any day. They can stay. All the sweetness in life. Yeah, he puts sugar in our cocoa. That's right. Ultimate Health on Joy 99.7 FM. So past 2 weeks, following World Brain Day, we've been hosting neurologists, members of the Neurology Society of Ghana. Today we're back on the beat and we're continuing our education on stroke, causes, symptoms, types and treatments. Today I have Dr. David Brody Menza. He's back. He's a neurologist with the Kolibu Teaching Hospital. And then Dr. Nana Ekua Sarah Opoku Achampong. He's a neurology fellow and physician specialist, at the Greater Accra Regional Hospital. And they'll take us through part 2 of our dissection of stroke. What is it? What causes it? Are there different types? What were the risk factors? Last week we got bogged down, especially when it got to hypertension. Oh my goodness. Today we want to do more justice to the actual event, things you should know, and then we should be able to move into treatment and management. Docs, you're welcome.
Thank you for having us.
Thank you.
And you served me last week, Dr. Brody Menz, and you left me with the two ladies. Not that I'm complaining, but welcome back.
Good to be back.
You
Apologies for last week.
Yeah. It worked on our brains, but we had worthy resource persons in the studio. Dr. Opoku Achampo, am I right?
Yes, you are.
You're most welcome. Why? I beg you, can you check her mic? Yes, you're welcome.
Thank you. Thank you for
Is this your
having me,
first time
Nortey.
here?
Yes, it is.
Oh, okay. You work on our
On
brains.
your show.
On my show.
Yes.
Okay. Okay. You've been on other shows.
I have.
Okay.
I have.
Right. Great to have you. Every Sunday, 2:05, we come alive. We try to, should I say, empower, inform, transform. Many of our discerning listeners know a bit or two, but every Sunday we gather to do this. So we started the journey with regards to stroke. Let's just recap, what is a stroke? Every, physician, doctor has their own way of explaining it to the benefit of our listeners. Let me start with you, Dr. Opoku Achampo.
Okay. Thank you. Thank you once again for having us. So when we talk about a stroke, basically what we are saying is it's when there's decreased blood supply for whatever reason to the brain, to any part of the brain. And we should remind ourselves that blood carries oxygen and nutrients.
All right.
So if the brain, any part of the brain is being deprived of this, then that part cannot work. Mm-hmm. So if that part can't work, then depending on which part of the brain controls which part of the body, then you find people not being able to function properly in terms of that.
Okay, right. And like Dr. Chawe Feli said last week, every day is brain day, right? The brain is so central, so critical, so, should I say, important, that anything that impacts, affects, compromises brain function and well-being, we need to be mindful of this. Okay, having said that, so we are talking a situation where a part of the brain is deprived of adequate blood supply.
Yes.
All right. And that leads to some damage, compromised function, right? Sometimes we hear of a partial stroke. Is it the same thing but not so serious? Is it a matter of degree, severity?
Well, basically, like you rightly put, if oxygen and nutrients are not getting to that part, then the brain won't function properly. If for whatever reason the starvation to that part wasn't prolonged, then you hear people saying partial, because what they interpret as partial is probably for a few moments or a few seconds or a time in space, they are able to, somebody's not able to talk properly or have slurred speech, and then for whatever reason, now the person is talking properly. So say, oh, you had a partial stroke, but now you're fine. Okay. But then we are still worried about such events.
Okay. Right, Dr. Brody Menz. So let's say I have experienced a stroke. How can this be properly and conclusively identified, classified, or diagnosed? Who will tell me it was a stroke and not just a bad headache or not the effect of some substance I went to take? I mean, who conclusively will diagnose, identify a stroke?
Thank you for the question. One thing I would say, just to go back a little bit on the partial stroke, sometimes people talk about the severity as well. So we talked about the duration, but sometimes the severity. Sometimes people expect like whole paralysis on one side of the body to mean you've had a stroke. But sometimes, depending on which area of the brain is affected, you may not get that full paralysis. You may get partial weakness. So sometimes people describe that as a partial stroke as well.
Okay.
Coming back to the diagnosis, the thing we usually want to, first of all, let the general public be aware of is that there are certain signs that point towards the fact that you may be having a stroke. And I think we talked about it last week. We used the acronym B FAST.
Right.
So things like having problem with your balance, changes in your vision, blurry vision or loss of vision for the E. F, if there's a weakness on one side of the face or droopy face. A standing for weakness in the arm or the leg. S, something affecting your speech. And then T, meaning it's time to call for help and get to the hospital as quickly as possible.
Okay.
So these are some of the things that can indicate that you may be having a stroke.
Okay.
And then usually when you get to the emergency room, whichever emergency personnel, doctor or attending who is there will be able to diagnose that this is likely to be a stroke. And then they make that diagnosis clinically, and then we confirm by doing brain imaging.
Okay, folks, 13 minutes past the hour of 2 on Joy 99.7 FM. We're continuing our discussion on stroke causes, types, symptoms. Doc Brody Menz just mentioned a couple, right? Those things can be caused by other things, right? But we need to be on the alert, look out for these things, especially when they present together, right? Sudden onset, right? And we want to get all of you in tip-top vigilance when it comes to these things. We've also talked in earlier weeks about risk factors that may lead to this. We're just trying to recap quickly so that we can get into the actual event, right? What will we see? What will we experience? What should we be doing? And then we'll get to consider some management and treatment priorities and modalities available here in Ghana. If you have any questions, concerns, WhatsApp is 055 11 11 997. We're live on Facebook and YouTube. And shortly I will activate the phone line so you can have a neurologist all to yourself to ask questions. Okay? I've got Dr. Opoku Achampong in the studio and Dr. Brody Menz in the studio. I mean, that's a good squad, all right? So very soon I'll activate the phone lines, but WhatsApp gets you straight through. I'll read out your questions, concerns, experiences, and we'll try and make some gains. So coming back, so once you move to the facility, and we did establish from the get-go, the first program, that this is actually a medical emergency. It's not something you sit and wait and think and talk about, right?
Very true.
It's a medical emergency.
Yeah.
All right. Can you just clarify that for my listeners? When I say it, they think I'm just doing my usual stuff.
So we usually say that brain is time. Sorry, time is brain.
Right.
So the thing is, the sooner you get to the health facility for it to be identified that you're having a stroke. Depending on the type of stroke, there are some medications that can be given that may help improve the outcome.
Okay.
So the sooner you get to the facility, the better. That's why it is one of the reasons why it's an emergency.
Okay.
Another reason is that there are also some acute complications that can happen. So for example, a lot of times when people get strokes, it might affect their ability to swallow.
Okay.
And if that is not picked up early and the person tries to eat or somebody tries to give them something to eat and it goes the wrong way into their lungs,
Right.
they can do it. It's causes what we call aspiration,
Right.
which is basically like food going the wrong way into your lungs, and that
Okay.
can cause its own complications.
Right.
So these are some of the reasons why we want somebody who's having a stroke to get to the health facility as quickly as possible.
Okay. Then that is also dependent on your ability, your capacity to identify the signs and symptoms and react swiftly, promptly, like my docs are saying. Like I said, if you have any questions, concerns, WhatsApp is 055 11 11 997. Shortly, I will activate the phone lines. We are also live and active, I believe, Abeku, on Facebook and YouTube as well. This is Ultimate Health on Joy 99.7 FM.
99.7
Okay,
FM.
so we've understood this is an emergency. Okay. Do we need to go back into what could cause this stoppage, cessation, deficiency of blood to the brain? What are the typical things that could lead to this event?
I think we can go back to the concept of risk factors.
Risk factors.
Yes, we talked about it last week.
Okay.
The hypertension, we can't stress it enough because it's one of the largest, actually it is the largest risk factor for stroke, uncontrolled hypertension. So last week we talked about...
Uncontrolled, unidentified.
Well, yes, that's so the different stage in the fact, the burden, if you actually look at it, first of all, is the fact that, I mean, a large percentage of people have elevated blood pressure, but they don't know
All right.
they have elevated blood pressure. So in fact, if you look at some of the research that has been done in Ghana, as high as 2/3 of the people who have elevated blood pressures do not know
Okay.
that they have elevated blood pressures. So that's the first hurdle. The second hurdle is actually getting the blood pressure controlled. So if you've identified you have high blood pressure and you've gone to a health facility and you've been put on medications, we want to get your blood pressure down to back to the normal range, preferably 120/80. And if it's still high and it's not controlled, your risk for stroke still remains elevated. So
Okay.
again, about only 50% of people who are on treatment
Okay.
actually get to their targeted blood pressures.
All right.
So this is one of the biggest risks.
Hypertension.
Hypertension.
All right.
I mean, there are others. We talked about them again. The diabetes, elevated cholesterol, and physical inactivity. Some people who are overweight, smoking, having high salt in your diet,
Right.
not taking a lot of green leafy vegetables.
Okay.
These are some of the risks that have been identified.
Risk factors, folks. If you're with me on 99.7 FM, Joy FM, right? These are risk factors. We are hoping today we will not derail into a whole program and discussion on the risk factors so that we
Yeah.
can actually, can I say it in quotes, have a stroke? Yeah? We'll do that, have a stroke and understand what takes place, what is happening to the person, all right? Or to you, right? Over 2/3 of adults, okay? 1 in 4 persons, I believe that the cutoff was over 25, is likely to have some of these combinations of risk factors and will actually experience a stroke.
Yep.
Then Dr. Chawe Feli's surprised, shocked, blew me out of the world and said, for those over 18, 1 in 2, right, has features, right, that could bring them closer to the very topic we are talking about. This is serious stuff, okay? Serious stuff, okay? Even if the statistics may vary for different samples and different researches, this is big stuff. So we need to understand that. Okay, so let's say we can talk of those caused by a blockage, right, to a vessel supplying the brain, and then what? A burst or a breakage in a vessel, okay? Blockage and burst, for some people, are they really different in outcome in terms of the nature and the management of the stroke?
So,
Yep.
so in terms of management, yes.
I like your baton changes. Right?
So in terms, just to go back a bit
Yeah.
before I answer this with the risk factors. So usually would classify them as modifiable and non-modifiable.
The risk factors, yes.
Yes.
Yeah.
So the modifiable is what Dr. Bodimens elaborated
Things you can
on.
change.
Things you can change, and
Right.
which we advocate that people should take a closer look at and make sure at least something you can change is very easy to do. Things you can't change, like you're saying 18 years, and now you have an increased risk of getting a stroke as opposed to somebody, say, 10 years or 12 years.
Okay.
I mean, there's nothing you can do much about.
So your age.
Your age, your race, your sex, all that. So that is why it's very important to work on the things you can really change to really reduce the risk of you getting a stroke.
Okay.
Now, with in terms of management, you asked about bleed or rupture
Yeah.
versus if there's a blockade. Yes. So in terms of management, yes, there are
99.7
different
FM.
medications we will give for one over the other. Like Dr. Bodimens couldn't have said it any better. That is why it's important to know some of the signs and symptoms. And like
Okay.
you rightly said, when it's sudden, so like your balance, if you're not seen properly, you need to go to the hospital ASAP.
Okay.
When you get there clinically, it's picked up by whoever is on call and they do the imaging. That is the only way you're able to tell whether this is as a result of a clot. And most of the time, it's usually from high cholesterol, which kind of boils down to the facts that, our eating habits and all that probably spoke about last week. So management is different,
Okay.
a bit slightly different in terms
Okay.
of how we bring our blood pressures down and all that.
Okay, let me look at you both with what I call sign language eye. My look is telling you things, but we say fast. Okay, look out for these things, facial changes, whether you're able to smile and all that, whether you're able to raise your arm, move your arms, whether there's a change in speech and all those things. Fast. But essentially, if I move somebody or I even move myself to a facility, does that presuppose, or can I expect that there's a unit, there's a certain priority and urgency if you bring a stroke to a health facility? You say, please, is that going to happen, or are you going to get there fast? And then we slow things down and we say, wait, and we'll have to do this and that. How is it handled? It's not the event itself, but I just want my listeners to understand the seriousness we attach to this.
Well, I think now doctors are up and coming. There's been a lot of awareness. That's where Neurology Society of Ghana is doing a great and awesome job. But a lot of doctors are well informed. So if you came to the hospital with such symptoms, you'll be more than assured that there'll be an urgency.
Pronto.
Pronto. Hopefully, there's a imaging facility in the hospital, and that works.
We can
but
get
yes,
all the
hopefully.
imaging we need to do. If it is a what? What is the typical regular one? Is
The
it
CT scan,
the
plain
CT scan, yeah.
right? Okay.
We that will be a political answer, but most the
You're being nice. It's a challenge.
it's a challenge. No, it's a huge challenge.
Right.
It's a huge
Let's say
challenge.
it, right?
It's
Hit
yes.
it.
Let's
Yeah.
hit it on the
Hit
nail.
it the way the stroke will hit my brain.
Yes,
We
it's
have a challenge when it comes to medical imaging, which is critical and
And the-
essential and maybe even non-negotiable when
True.
you want to pin down what has
True.
happened to the person.
True.
All right, you're
True.
too nice.
True.
All right.
Yes.
So yes, it's a challenge.
Okay.
It's a challenge. Even in the big facilities, sometimes they are supposed to be there, but they are not working, which is rather unfortunate.
All right, folks, when I say imaging, we need to be able to see inside your brain, right? The CT scan, an X-ray is imaging. Ultrasound gives us some imaging. But when we're going higher level, yes, CT, would you get to MRI?
You may get to MRI.
You may get to it. These facilities and this technology must be available so that you see these nice neurologists and things like that. But if they are handicapped, right, by these things, then some of the determinations they may make may not be as accurate or precise as they need to be. And that may slow things down. Okay, Dr. Opukwa Champon was being nice, political. And they say politeness is the most common form of hypocrisy. Please, we have said it. We need these things to be able to do that. All right. So we've arrived at the facility, right? And you pray that we have these things. Anything else?
Yes. So one of the medications, and that is also one of the challenges. One of the medications we use to break the clot, for the one that has to do with the blockage
All right.
of the blood vessel, there are medications that we can use to break the clot. Unfortunately, these medications are
see.
either unavailable or very expensive
All right.
at a lot of our facilities.
So what you're saying is we realize it is due to a blockage.
Yes.
There's something which we administer or can and should administer quickly to dissolve or break up the clot.
Yes.
To-
For the people that arrive, let me qualify that. For the people that arrive within the proper window,
All right. If you
because
get there
not
on
everybody
time.
can receive it. But
All
if you
right.
get there on time and you can receive that medication, then the challenge comes that in some places it may not be
It's
available
in
or
short supply or
it's too expensive.
it is out of reach financially. All right. 055 11 11 997. We're live on Facebook and YouTube. This is Ultimate Health on Joy 99.7 FM with me, Nortey by nature. I've got some, doctors in the studio. They are neurologists, right? They deal with the brain and other related structures, right? That's serious stuff, eh? And we're looking at stroke, very common, right? And some of the risk factors are also highly prevalent or very common. Unfortunately, despite this high prevalence, many of us, and even the familiarity with the things, many of us are not aware that we have one or more of these risk factors, okay? And we're not taking them seriously. And even when we are aware, not many of us are getting the optimum treatment or are compliant with our management. 055 11 11 997. We're live on Facebook and YouTube. We're looking at causes, symptoms, types, and treatment of stroke, right? A brain event, a medical emergency where your brain or some part of your brain is not getting adequate, right, blood supply. Serious stuff, right? Maybe I'll announce the phone lines a bit earlier. 030 221 6541 030 221 6541. And my guests, of course, apart from being qualified, are members of the Neurology Society of Ghana. They are pushing the agenda as part of the World Brain Day and then follow-up activities to empower, inform, and transform you. Daniel says, good afternoon, my name is Daniel. Please, I'm asking, if someone finds themselves in a state where they like eating fresh meat, please, can this person get a stroke? Oh, Daniel. Fresh meat and a state where you like eating fresh meat, okay? That's what Daniel is asking. Let me just read a few more. Oh, yeah, in Afianya, I see you. First in class as always. All right, I'll buy you toffee. I can't say toffee. They'll say I'm slanging or something, but toffee. Hi, this is Taylor. I want to ask regarding the program discussion on stroke, are there factors, causes, symptoms that differ between male and female? So we've got modifiable factors, that these are the behaviors, preferences, practices that you choose to download but are damaging your brain health. And then they're non-modifiable whether you're male, female. And he's asking, would there be should I say, a distinct or qualitative difference between the factors, the causes and symptoms for males as compared to females?
So to take that one, it's I would say that first of all, you have, like we discussed, the non-modifiable. So that gives you a sort of underlying risk. So as you grow older, if you're a male, your underlying risk already is high. So when you now get some of these additional risk factors, it comes to add on. So which is why in a lot of places you realize more males tend to get strokes than females.
Okay.
Because even though females and males can both get hypertension, can both get diabetes,
Okay.
it's coming to add on the already high risk a male has, also higher risk that a male has as compared to a female.
Okay.
There are also some studies that show that for females, if they are premenopausal, some of the hormones can protect them against some cardiovascular disease.
Okay.
So these are some of the differences,
cause
sex differences,
right.
that may cause
Okay.
some changes in the risk.
But bottom line, you don't want to get there.
Exactly.
Whether you are male or female, you don't want it.
Exactly. You want to keep your risk as low as
Even
possible.
if you are menopausal, postmenopausal, and like my dog says, it helps you in some way, please don't go there. Didn't, wouldn't, shouldn't, couldn't. All right. I keep hearing go to a health facility and imaging. Does every health facility have imaging equipment? We just talked about that. I put the questions to them like the OSP, and they pleaded guilty with explanation, right? We have a challenge in that regard. Any of you who's, having challenges with too much money and you want to sponsor something or do something good, please, these are the things we should be looking at, right? Mobilizing resources to see. I mean, I don't know what it costs, right? But I know some of you have a lot of dosh, right? So, yes, there's a challenge when it comes to the imaging equipment required to make prompt assessments in the instance of a stroke and other conditions. The doctors concede that this is the case, so I'll send them to IUCO. But I asked as the OSP, they pleaded guilty with explanation. Do I have any others very quickly? So Daniel asked about male, female, right? And then fresh meat. Yes, there was one about fresh meat.
So the one about fresh meat, there is actually some research to show that people who do have a diet that is high in consumption of meat are at a slightly higher risk of stroke as compared to those people
Why
who have
so?
more of I think it has to do with a combination of diet in total, because definitely if you have a diet that's high in meat, you're taking in more cholesterol, you're taking in more fats.
All right.
And then these components we know already are increase your risk. Also, there's also the concept, some people also have found that having high uric acid levels can also be a contributor to inflammation and also increasing your risk for cardiovascular disease.
All right. There's a lot of things we need to moderate or desist, especially when we sit in front of these learned doctors. They will tell us this one, that one, that one. The other day I was picking up, was it a pizza somewhere? So I said, are you not Edward? You eat pizza. Hold on, let me call my wife. Please take the advice seriously, even if you catch me doing some of the things that we shouldn't be doing, right? It's serious stuff. You don't want to get there, all right? We mentioned that there's really, literally no family that has not been touched by the things we're talking about, right? So let's take them seriously. 31 minutes past the hour of 2 on Joy. Oh, my brothers and sisters on my WhatsApp. Can sex positions cause stroke? Doctors, it is Sunday, but I didn't send it, I didn't type it, but I have received it. Sex positions, is there any of them? I am not saying that you are sex consultants, all right? But if you are, you can tell us, right? My listeners love that, and then the program will change totally from that point. But sex positions, stroke.
It's actually a very common question we get asked, but there has, to the best of my knowledge, there hasn't been any particular position that has been found to increase. But I have to say that the act of sexual intercourse itself has been associated with elevated blood pressures, especially in men.
Seriously?
So that is, because of the excitation that takes place. So if you have high blood pressure already, your blood pressure is not controlled. It's the chance that your blood pressure at that point in time can shoot up and increase your risk. So not the position itself per se, but the underlying risk factor that has not been
Your
controlled.
own physical well-being.
Yes.
Want to miss spell intro, right? That's what I'm saying. So, I mean, be mindful of where you are, where you stand, your health status, okay? Before you go and watch something or hear something and you want to do some. That's what my doctor is saying. But no position has been proven, right, to have a higher, relationship.
Risk.
Okay. All right. We've answered that. I thought we'd dodge it, but we've answered. Okie dokie. You guys don't want us to have the stroke. This week we will have a stroke. Good afternoon, please. What are the medications, losartan and amlodipine combinations? What are these medications, losartan and amlodipine combinations to control high pressure and thinning? You want us to tell you of the medications? I'm not quite clear. You are aware of the medications, okay, and that they can be used in combination, but I'm not sure what you want the doctors to tell you. So I'll perhaps plead that you come again on that, all right?
Well, the two medications he's listed are used to control high blood pressure.
Yes.
Not necessarily for blood thinning, though. The fact that I'm out.
He wants to get into territories he's not qualified for, unless he tells me and sends his qualification. All right. Some people want to hear these things, and suddenly they're off to the pharmacy. Okay. Good afternoon, Nortey. Do we bad breath? Hang on. Let me scroll.
No, I think that's a different date.
Yeah.
All right. This is March 31st.
31st.
Hey, this is the positions guy. All right. So you do have a a history of questions here. All right. So 030-221-6541. The phone line is activated. You can ask the questions directly to my neurologist, Dr. Opoku Achampong, and Dr. David Brody-Menz. They are in the studio on your behalf, really, but they will answer your questions if you ask them. WhatsApp is still 055 11 11 997. No more questions on sexual positions. Just be good and be careful. All right. So we come back. So let's come to the event. What really is happening to me, or what will I experience? Of course, people around me should look out for certain things. I should look out. But what is the experience, and can we go through that?
Be fast. Dr. Brody-Menz mentioned earlier on. So the mnemonic he used, be fast.
Right.
So if, for instance, Nortey, you walked into your studio this morning, you woke up fine, well, as you usually do. Okay, so we won't use Nortey, then we use Hex.
No. I receive it in his name.
So hypothetically,
I woke up
God
fine.
forbid,
Okay, right.
and you come and all of a sudden you feel you're swaying to one side, or you feel you're a bit woozy, you're not well balanced. That could be a symptom.
Okay.
Or your eyes, you wear glasses, but then all of a sudden if blurry vision, which hasn't happened before, it's something to look at.
Okay.
Slurred speech, you realize that your lips are deviating, or your mouth is deviating towards a particular side. It's not like in the middle.
Okay.
Or weakness for no reason, apparent reason. You feel like one side is weaker than the other.
Okay.
These are things that should be bothersome and should worry you, and you should want to get to the hospital ASAP. I was trying to liken this, if supposedly you tied a rubber band or a piece of fabric around your arm, very tight. Initially you feel that naturally, because there's no blood flowing, there's going to be a bit of pain and discomfort. The earlier you let somebody take it off for you, the faster blood will flow to it, and then you wouldn't feel any discomfort. But when you leave it on for a very long time, you realize that your fingers will start to feel numb. There'll be pain, and then very soon you wouldn't even feel again. So just like Dr. Brody-Menz said earlier, time is brain. So the earlier you get to your primary facility for you to be checked out and for you to be diagnosed and started treatment appropriately within the time frame that doctors use, we usually say about 4.5. So any time between 3.5 to 4.5 minutes from the last time you actually felt normal. Sorry, hours. I beg your pardon. There's lots of things we could do to reverse this situation.
Okie dokie, you're hearing that serious stuff. But is it possible? I see someone, Sarah Manfo, I'll read that in a second. Is it possible, and we do hear that sometimes the imaging and the follow-up investigations can actually pick up a stroke that happened some time ago, that it is actually not a new event? Is it possible that I can have a stroke, it is actually a stroke, but I missed it and life has gone on? Is that also possible?
Yes, it is. There's actually something that we neurologists call a silent stroke.
Okay.
And that is a stroke that has happened, but depending on which particular area of the brain was affected, maybe it's a very small area and it's not very critical
Okay.
to the functions that you do every day.
All right.
So that might happen and you will not notice it. Or maybe it was very transient,
Okay.
just something small, some
Brief.
brief symptoms that you had and it went away.
Testing mic. It's a warning. Testing mic 1 2 1 2.
Yes.
Uh-huh.
And then maybe for some reason or something unrelated, we get to do a brain scan.
Right.
And then we realize that, oh, you've actually had a small, stroke in this particular area. And then sometimes they actually tell us that, oh, it's true. Some time ago I felt this or I had this, but it
Okay.
didn't last long.
Right.
Sometimes people didn't experience anything at all.
Okay.
So it depends on the size and then
All right.
the location.
Okay, so sometimes you've been living with the compromised function, right? And you think, oh, it comes and goes, or maybe I just become tolerant of it, right? But you may present at a health facility for some different reason, and imaging might pick up some of these things. Very often, one thing that I know happens is that when it is requested, people look at cost and all these things. They say, can you not detect and tell me, you are the doctor, how much am I going to pay for imaging? Can't we skip that and you tell me some? This is very, very essential. Dede was asking that, so if you don't have these facilities, how do you determine it's a stroke, right? Is it by description of symptoms, physical examination, or like you said, clinical features? But
Yep.
you want to be able to confirm with precision and accuracy.
Yes.
Right.
That also takes us to the realm of without being too medical or using too much jargon. Sometimes we have what we call stroke mimics.
Mm-hmm.
So sometimes there's some things that may seem to be strokes,
Okay.
but are not. So there are sometimes when we get some of these cases where we think it's a stroke, but we also think that there may be something else that might
Something else
explain
causing
it.
it, right.
So, for example, sometimes when you get an overwhelming infection, or sometimes if you have a low blood sugar,
Okay.
some of these conditions might mimic some of the symptoms of,
Right.
of a stroke. So, for example, somebody who is diabetic and comes in and then there's loss of consciousness,
Okay.
or the person has collapsed, and then we want to find out, is this actually a stroke, or could it be that maybe there's low blood sugar?
Okay.
So, we will treat the emergency, check the blood sugar, if it is low, correct it,
Right.
and that. And then we want to see, okay, is that all there is to it? Or maybe there's still, an event that has taken place.
Okey-doke.
So then the scans become quite important.
Right.
Again, another reason I'll go into this is, like we mentioned earlier, the type of stroke also matters. So even if we do know that you've had a stroke, we want to know what type it is, because you can't tell clinically whether it is a blockage
Right.
or whether it's a burst in the brain. It's the scan that will let you know which type of stroke that you're dealing with. That's another reason why the scan becomes
Okay.
important.
Right.
Then the last thing I'll also mention is that when it comes to the treatment, just not to jump the gun because we're going to talk about that.
Right.
When it comes to the treatment, there are some treatments that cut across both. So when you report to the health facility, we will do the emergency treatment that cuts across both. Okay, so that's even whether the imaging is there or not, you receive that treatment.
receive that.
Okay, but the specific treatment for the particular type of stroke, we need the scan to determine that.
Okay. Some people count the number of times I say okie dokie. I try to avoid it, but I replace it with okay. Nortey, please, no, hang on. I have headaches, and when I saw the doctor, he made me do or have an MRI. I was then diagnosed as having sinusitis. Please, I need advice because the headaches are still there. Please help, thanks. Then follow up, it says, Nortey, please, I had a mild stroke 2 years ago and was hospitalized for 3 weeks at the hospital. I felt fine when I was discharged, but I am now battling with an excruciating pain in my lower back region. I have complained to my doctor, but was given some painkillers which I found worrying. Please, what can I do? I am Edna from Osu. Before my doctors respond, please, some of these things must be rightly presented at a health facility to a qualified professional. It seems you've done that, but I'm just doing that. Otherwise, we get a whole load of signs and symptoms and histories. Anything you want to say to Edna?
So I'm not sure if Edna is the one talking about
99.7
sinusitis, but
Okay.
she's been having headaches for a while now.
Mm-hmm.
She says she was diagnosed as having sinusitis. Um, the thing about headaches is, I'm not sure where she went, but it'll be good to do a follow up on those headaches
Right.
because there are different types of headaches. You could have primary or secondary, some not related to strokes at all.
Mm.
So, depending on what kind of headache you do have, there
Okay.
are different medications for
Right.
them. So, if you're using wrong medications for a different like a different description of a headache, you
Okay.
may not get relief.
Right. So the headache in itself may be a symptom, right? And it can also have its own
Other
features.
right.
Right. Okay. Yes. And then she talked about 2 years ago having what she labels as a mild stroke. Okay. Hospitalized for 3 weeks and was fine when she was discharged. She doesn't talk about the treatment, but says she's now battling with an excruciating lower back pain and she's been given painkillers.
Again, she needs to go back to the hospital. She needs to have a follow up. Mild stroke, I'm not sure what she experienced. I'm not sure if she had an imaging than back then, what
Okay.
she was given. She says she felt fine and was discharged.
Okay.
Now she's having a lower back pain. It could be totally unrelated.
Mhm.
So I would advise Edna to go back and have it checked.
Okay, Edna, I hope that helps you. Good afternoon, please. Last week, I experienced frequent and painful shocks in my head, especially almost to the right side of my forehead. I went to the hospital and was admitted for a day, but they didn't tell me the exact problem. I am blind and it's caused by RP. All right? Does that tell us much?
I don't know. I don't know what RP stands for.
Okay. Give us a bit more detail, though. That's, we were trying to avoid getting into this kind of stuff. It says this is comfort in Sege, right? So frequent shocks in my head, right side of the forehead, and this person says they are blind. Okay. Something is coming up with the RP, but let me not rush. Please, what is heat stroke? Hey, let's see. Reverend Benjamin Quarter in Westlands wants to know. We're talking about strokes, but he brings up heat stroke. Any?
Well, heat stroke is it's a different entity. It's not due to blockage of blood
Right.
supply to the brain, even though it's called stroke.
Right.
It's more to do with overheating or dehydration, and the body's mechanisms for dealing
Okay.
with these situations become compromised,
Right.
and the complications that come from that.
Okay.
So that's a different entity.
All right. Hello, Judith here. I lost my mom last year due to a hemorrhagic stroke. She was just okay until one day she threw up after eating, then immediately went off. We rushed her to the clinic and realized she was in coma. A CT scan was done to confirm what really happened, but my question is, how come we didn't see any sign of it coming? Then you add, she was diabetic though. Doctors.
So, deepest condolences to Judith on her mom's loss. But again, I mean, she had a risk factor there. She was diabetic. I'm not sure if other risk factors were screened for. I'm not sure how well controlled her diabetes was. She probably did have a few telltale signs which were probably ignored. She throwing up, they said she had a hemorrhagic stroke. Maybe she had raised pressures, they call intracranial pressure in her head. That's why she threw up.
Okay.
So it was rather unfortunate, but maybe there were a few signs
Right.
they all missed.
Okay,
Yeah.
of course, if you're not, should I say, vigilant and you don't know what to be vigilant for, then you miss things. Maybe there have been earlier, softer signs, all right? And again, sometimes we forget that medical conditions and events, complications do co-occur. So everybody knows you are diabetic, and we think we're doing fine with the diabetes, but there could be other things, right? Okay, I have a caller on the line. Hello, good afternoon.
Good afternoon.
Yes,
Okay.
yes, sir.
Yeah, good afternoon to you and your resource people.
Right.
I have a problem.
Just tell us who we're talking to and where you're calling from, please.
Hypertensive.
Hello?
My mother,
Hello, hang on. Just tell us who you are and where you're calling from.
King James from please.
King James from Pram Pram. Okay, shoot.
Yes. I said my father died hypertensive. My mother also died hypertensive. I wasn't born hypertensive. I wonder if your resource people can tell me that at that tender baby age, I was hypertensive. However, growing up, 30 years now, I've been very hypertensive. And I've been on amlodipine and losartan for these 30 years. But I'm still having it. Does it mean the medicines are not working for me? Or what? I want to know, please. Thank you.
Okay, so you're currently confirmed hypertensive. You're on medication, and you say you still have the hypertension, right? My doctors will address that. Okay. I have another caller on the line. Hello, good afternoon.
Good afternoon, Nortey. My name is David. I'm calling from Lashibi.
Okay, shoot, David.
Yeah, hi. Around 2013, I had a mild stroke or a CVA, but this is my medical history. I had an open heart surgery around 1996. 2013, I had a mild stroke. I just couldn't. I couldn't swallow, and then my right side just went numb. I got admitted at an emergency. That's when I got to know that I had a mild stroke. I had a blood speech. So later on, I had to get a tube to get feeding. Eventually, I had to go for therapy, physiotherapy for a month before I resumed back to my nursing. But then, after everything, my left side has this burning sensation inside with needle pricking. It's on and off. Sometimes I can put it in hot water, and I don't even feel the hot water. Now I feel a bit of the hot water, but still, it's been from 2013 till now. I still can't. I still feel the burning sensation and then the needle pricking. I want to find out what would cause it, and is it one of the side effects from recovering from a mild stroke?
Okay. Right, mild stroke. He mentions a history of heart surgery or open heart surgery, and then he has loss of sensation, tingling, prickling sensation, and a burning sensation. I believe he said on the right side, but one-sided. Right. He's asking if this is related to his history. I have another caller. Let me quickly take that. Hello.
Hello. Good afternoon.
Good afternoon, sir. What's your name? Where are you calling from?
My name is Mr. Nortey. Is your friend Peter?
Peter, I spoke to earlier.
Yeah, you talked to me earlier. So I wanted to ask the doctor, is there any help that to control the BP? I wanted to know if there's a help that could control the BP. And then what you asked me, now I have done the thing, I've sent it to the WhatsApp, okay?
Okay. Right. Okay, so he's asking about help to control his BP. Do I have another? Wow. Hello, good afternoon.
Hello, Nortey.
Yes, sir.
Good afternoon. After you are a resource person.
Right.
Is it true? Is it of truism, that when you take these drugs like these diabetes drugs, and then they metformin, and then the hypertensive drugs, it can affect your kidney or other organs also.
Okay, so can these hypertensive drugs and metformin and diabetic drugs or medications, can they affect your kidney? Right, we have a lot on the table.
So maybe I'll start with Peter. Peter
Okay.
was a bit distressed.
Yeah.
So what you need to know is that there are different classes of medications that help control your blood pressure. You did mention that you were on amlodipine and losartan. I'm not sure if you're on maximum.
No, Peter was different from the one on amlodipine.
No, it's the
and
same.
losartan.
Peter called back.
No, this is Peter who had spoken to me earlier this afternoon. We know he has a history of diabetes and other things. There was another gentleman who
The
had
first
also,
caller.
Yes. Uh-huh.
The first caller was on amlodipine and losartan.
You go
Okay,
ahead.
maybe not Peter,
Yeah,
but the first caller, maybe
Yes,
I
right.
should direct to the first caller. So he was on amlodipine and losartan. I'm not sure if you're on maximum doses of it.
Okay.
But there are different classes of blood pressure medications that control blood pressure differently. And to most important thing that they all bring your blood pressures down. So again, they need to go to the hospital.
All right.
They need to do what we call a BP profile, have their blood pressures checked, especially when they are home or like when they are very comfortable. Let's see what the numbers are looking like.
Right.
And then maybe the doses may be increased or a different class of drug may be given.
So your doctor essentially is looking at some targeted management level. They want to bring your blood pressure to a certain level. Over time, they'll determine whether they are achieving that and whether there's a need to review that
Correct.
or modify based on certain other things they become aware of or developments over time.
Correct.
Okie doke. Yep.
And then two things I would want to add as well. One is the fact that if you have a family history of hypertension, one parent, second parent, it actually increases your risk of developing hypertension.
All right.
In some cases, even as much as twice, as doubles your risk. And then also to mention the fact that for most cases, if you've been diagnosed as hypertension and it's primary, meaning that there's not another disease that is causing your hypertension that can be treated, but primary hypertension, or what we call essential hypertension, you're going to need lifelong treatment. So it's not somebody who's taking the medications expecting that hypertension will go away and he will no longer need to be on treatment. Most cases you need to be on these medications lifelong.
Okie dokie. Right. Dede is saying that it seems that people stick to their doctors despite getting results. She's in the US, she's in Maryland. I realized from the questions and comments that people stick to their docs without getting any results. Why then do they seek a second or third opinion from other doctors? She's asking that. She said, should it be, is it by discretion? Should it be that the patient can't talk? I guess when she mentioned the challenges with imaging, what perhaps would happen if the patient can't talk and someone chanced on and without knowing what happened and rushed the person to a health facility. So she's looking at our challenges up there. But she's saying that from what she's hearing from the calls, comments and questions, people don't seem to be getting relief. I don't want to immediately automatically accept that, but I do get the sense that there may be challenges with explaining what is being done, what is wrong with them, and what the treatment modalities are and the targeted goals or outcomes.
Okay, so that's actually a good segue into something I wanted to talk about before our time runs out, and that is the sort of like the course of treatment. So quickly summarize: after you've had a stroke, we've talked a lot about the acute treatments, preventing the complications, and trying to see if you come within the right time window and it's a clot, if we can burst that clot. That is all part of the acute treatment. Now there are other components of treatment. There's what we call secondary prevention, meaning medications that will put you on to reduce your risk of getting another stroke. And then there's also what we call rehabilitation. So meaning that if you've had some parts of your function that has been affected, the brain has what we call neuroplasticity, meaning that it can learn again to redo some of these things. So there's rehabilitation, so things like physiotherapy, occupational therapy. Where there's usually a lot of confusion is that this rehabilitation usually takes time. The brain is not an organ that recuperates immediately. So it's not like you take one medication and then within the next 30 minutes, 40 minutes, you go back to the state you were before you had the stroke. So the rehabilitation takes months, some cases even years, to improve function. And again, not all cases will go back to being exactly the way they were before they had the stroke. Sometimes there may be some residual deficit. So sometimes I realize that this is not clearly communicated to some people, and they sort of get upset with their doctors because it's like they're not getting any results from in terms of the rehabilitation, and they're not seeing any improvements. But I think
they are measuring and should I say measuring the differences in a totally different way, and the expectations need to be managed.
Yes, the management of the expectations. Yes. So I think if that is communicated to them appropriately, then rather than going to see, different doctors to try and find out exactly, if that communication is done and the understanding of what the rehabilitation process is like, then maybe the second, third opinions might be avoided.
Comfort, who mentioned that she was blind due to RP, retina pigmentosa.
Oh, retina pigmentosa.
Right. I was going to say retina something or retinol something, then I decided to keep quiet. But she shared that. Does that change anything on her issue she shared? Painful shocks in her head, right side of her forehead, went to the hospital and was admitted for a day, but they didn't tell her the exact problem.
I think I'll also ask her to actually follow up with her physician, because it doesn't sound to me like a stroke, but there are a number of things that might cause her to have what we call neuropathy, which can explain some of those painful shocks in her head that she's having. I'm not sure if there's any associated with RP to the best of my knowledge, but I'll prefer if a doctor does a complete workup.
And the doctors you're having now, Edna, probably and presumably have your history, right? And so they can tie together the pieces and explain them to you. But we're grateful that you share them with us on Ultimate Health as well. It does take a lot to get people to understand what is happening to them, especially when there's loss of function, right? And there's a whole chunk of denial. And indeed, I have neurologists in the studio, but the team, the stroke team, is a whole range of professionals. It's a multidisciplinary team: psychologists, occupational therapists, speech therapists, physiotherapists, you name it, right? So there are various aspects of your functioning that may be compromised, right? And you may be able to make gains and get some of them back close to normal. But like my doctors mentioned, there is the likelihood of residual damage that doesn't go away, and that is why you have things like occupational therapy that teach you how to do things differently, right? If you were left-handed and that goes, you're going to have to learn to do certain things with your right hand, your less dominant hand, and many other things. And probably we'll bring the team in also to talk about those things. Did I leave anything out? Is there something we didn't talk about? The tingling, the guy with the tingling on the right side, post heart surgery and post stroke.
It's possible that it is a complication of, depending on which parts of his brain was affected. So if you look at some what we call sensory pathways, there are certain parts of the brain that sensory pathways pass through. So if one of them was affected when he had the stroke, it's possible that might be responsible for the tingling on one side of his body. So it's possible, but I can't confirm without having his full history and clinical imaging.
Okay, Dede comes in again from Maryland. Some docs are just for primary care, so why doesn't one see a specialist? We don't have the benefit of the full facts and who they are seeing, right? We only have what they write and send to us. This is why I try to, some people say I protect my guests, but really, you can't just listen over radio to somebody's presentation. You haven't seen them, you haven't heard anything else. Then suddenly they say, oh, actually, somebody added that later, that I'm diabetic at the last part of the, you need a full history. You need to take a lot of information in before you arrive at a diagnosis. So that is why, yes, but the gentlemen, the people I have in the studio are specialists and close to specialists, and they do have the capacity, and there is a referral team anyway of seniors as well. But we cannot tell whether those who are sending us these questions and experiences have the benefit of a specialist or not, and whether what they've been able to type quickly to Ultimate Health is the full story. Right, docs, anything you want to leave us with? Sadly, we've run out of time. We did manage to have a stroke and understand it, right? And that is to equip our listeners. I would want to emphasize on prompt response to any of these things. Even if you get there and they say, oh, it isn't a stroke, I prefer that to hanging around and finding out it was a stroke. But anything you want to leave us with?
I'll once again hype on prevention.
Okay.
As much as possible, even though there are things that can be done if you do have a stroke to sort of help your recovery, we want you to avoid getting the stroke in the first place.
Right.
Okay, so like we've talked about, look out for your risk factors that are modifiable and try and reduce them as much as possible, with emphasis on hypertension.
Okay, Dr. Nana Sarah, am I right?
Correct, sir.
Opoku Achampong.
Yes, please.
Anything you want to add to that?
So Dr. Brodimans couldn't have said it better. We don't want you having a stroke.
Okay.
So for me, lifestyle is key. Everything in moderation. Make sure you're always checking your numbers. Don't say I'm not diabetic, I'm not hypertensive every now and then. The same way we take our cars to the workshop to have the oils changed and brake pads checked.
All right.
We shouldn't say, oh, I'm not sick, I don't go to the hospital. We should make it a point every now and then, 6 monthly, yearly, just to go to the doctor and say, I want a thorough checkup done.
Okay. Prevention. Judith was the one who shared the sad story of her mom's passing. And I guess from her narration, there was really no warning. It just suddenly happened, and sadly, they lost their mom. So folks, this is serious stuff, okay? Of course, I add a dose of humor in and out of it, but I shared last week, my family hasn't been spared. I lost my dad, a gynecologist, years ago. Somebody hit the back of his car. He got out to talk to the person. They even helped push the person's car to the side. Then they noticed he dropped his glasses,
Oh dear.
right? And he was carried to the very hospital he was working in, right? Now the Greater Accra Regional Hospital. Okay, of course, he survived that, had neurosurgery, but I think 5-7 years on, we lost him. Okay, so these are real things, and people have been generous and, I say, courageous in sharing their information, but it is totally redundant, useless, and a waste of time if it doesn't inform and transform you. That's what we try and do this and every Sunday. Many thanks to the Neurology Society of Ghana. We will look at other conditions. I'll see if I can bring a stroke team in so that you see the spread of the domain of things they try to handle after they've, stabilized the issues and are actually now into rehab, which is a journey, not a destination. It's a journey, not a destination. And of course, downstream, we also will be talking about seizure disorders or epilepsy and many other brain-related syndromes and conditions. Many thanks to my docs again, Dr. Opoku Champon, Dr. Brody Menz, and Dr. Abeku Sankofi, my producer. And of course, you, my discerning listeners, you make it complete this and every Sunday. And we will do same again with his blessing next week, 2 o'clock. Stick and stay on Joy 99.7 FM. Don't go away. Abeku is up soon.
Yeah.